This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Annals of Medicine, published in 2026, titled Thoracic Paravertebral Block with Different Doses of Liposomal Bupivacaine versus Ropivacaine for Postoperative Analgesia in Single-Port Thoracoscopic Lung Surgery, a randomized clinical trial.
Now, Alara, some of our listeners, especially the residents, might be wondering why a neurosurgery podcast is diving into a study on thoracoscopic lung surgery. But as we know, the thoracic paravertebral block, or TPVB, is a cornerstone of regional anesthesia that we often see utilized in complex spine cases, particularly those involving thoracic approaches or rib resections. Understanding the longevity and efficacy of the local anesthetics used in these blocks is vital for our postoperative multimodal analgesia strategies.
Exactly, Dr. Aris. The goal of this study, led by Li Yuen Ren and colleagues, was to evaluate the analgesic efficacy of TPVB using two different doses of liposomal bupivacaine, or LB, compared to the traditional gold standard ropivacaine. They focused on patients undergoing video-assisted single-port thoracoscopic lung surgery, which, despite being minimally invasive, still carries a high risk for significant acute and even chronic postoperative pain.
Right, and that pain can really impede the rehabilitation process. We're always looking for that holy grail of analgesia, something that covers the peak pain period, which usually lasts 48 to 72 hours, without the complications of a perineural catheter.
That's where liposomal bupivacaine comes in. It uses multivesicular liposome technology to allow for the sustained release of bupivacaine. The idea is that it maintains local drug concentrations and reduces systemic absorption, theoretically extending the analgesic duration significantly beyond the 6 to 12 hours we usually get from plain ropivacaine.
So, walk us through the study design. How did they set this up?
It was a single-center, prospective, randomized, double-blind, controlled trial. They took 105 patients and randomized them into 3 equal groups. Group LL received a low dose of liposomal bupivacaine, which was 133 milligrams. Group HL received a high dose, 266 milligrams. And Group R, the control, received ropivacaine, specifically 20 to 30 milliliters of 0.25 to 0.5% concentration.
And these were all ultrasound-guided blocks?
Yes, all patients received an ultrasound-guided TPVB at the T5-T6 level preoperatively. The primary outcome they were hunting for was the area under the curve, or AUC, of the numeric rating scale, the NRS, of pain specifically during activity. They looked at this from 1 hour to 72 hours postoperatively.
NRS at activity is a much more rigorous metric than pain at rest. It's the stress test for any analgesic. What did the primary data show?
This is where it gets interesting. The researchers found that while the AUC for pain at activity differed significantly among the groups, with a p-value of 0.0092, the high-dose LB group was only superior to the low-dose LB group. When they compared high-dose LB to the ropivacaine group, there was no significant difference.
That's a bit of a negative result for the liposomal bupivacaine, isn't it? We often hear LB touted as the superior, long-acting choice, but here it didn't beat out a standard ropivacaine block for the primary outcome.
Correct. The study concludes that LB combined with TPVB is actually not superior to ropivacaine for postoperative analgesia in this context, even when looking at secondary outcomes like the AUC of pain at rest or the NRS scores at specific intervals, 1, 6, 24, 48, and 72 hours, the group-by-time interactions weren't significant.
Let's talk about opioid consumption. In neurosurgery, we are incredibly focused on opioid-sparing protocols to avoid the sedation and respiratory depression that can mask neurological changes. Did the high-dose LB at least help there?
It did show a dose-dependent effect. Cumulative opioid consumption at 24, 48, and 72 hours was lower in the high-dose LB group compared to the low-dose group. But again, when compared to the ropivacaine group, there was no statistically significant difference.
So if the ropivacaine, which we know has a shorter half-life, performed just as well as the long-acting LB over a 72-hour period, what does that tell us about the physiology of the block?
The authors dive into this in their discussion. One possibility is the single-point injection technique. Liposomal bupivacaine is a suspension of multivesicular liposomes, which makes it more viscous than ropivacaine. In a paravertebral space, which is essentially a series of wedge-shaped compartments, the spread of a suspension might be more limited than a clear solution like ropivacaine.
That's a great point. If the drug doesn't spread across multiple segments, you aren't getting that ipsilateral somatic and sympathetic blockade we need. They suggested that maybe a multi-point injection would be more effective for LB.
Exactly. Another factor the paper mentions is the onset of action. Ropivacaine works quickly. LB has a slower release profile. Some centers mix LB with plain bupivacaine to provide an immediate bridge of analgesia, but in this study, they used LB alone in the LL and HL groups. This might explain why the early postoperative pain scores weren't lower in the LB groups.
It's also worth noting the dosing. The high dose here was 266 milligrams, which is the standard vial size. The study showed that this high dose was definitely better than the 133 milligram dose for pain at activity and opioid sparing, but it still didn't cross the threshold of being clinically superior to our standard, cheaper ropivacaine.
And we should mention safety. One of the concerns with higher doses of local anesthetics is toxicity, but this study found no significant differences in adverse events or postoperative recovery across all three groups. So high-dose LB is safe in the paravertebral space, even if its efficacy didn't blow us away.
For the residents listening, what are the key messages the authors wanted us to take home? I saw they listed a few specific points.
The first is that this is the first study to compare these two specific doses of LB against ropivacaine and TPVB for thoracic surgery. Second, neither dose of LB showed superiority over ropivacaine in reducing pain scores or opioid use over 72 hours. And third, they concluded that single-point TPVB with LB alone might not be the most effective alternative to ropivacaine.
They actually suggested that we need to optimize strategies. They mentioned ultrasound-guided multi-point injections or combining LB with plain bupivacaine as future studies.
It really highlights that long-acting doesn't always mean better if the delivery method isn't tailored to the drug's physical properties. For a neurosurgeon performing a multi-level laminectomy or dealing with thoracic trauma, a paravertebral block is a powerful tool, but this study suggests we shouldn't rush to replace ropivacaine with liposomal bupivacaine just yet, at least not with a single injection technique.
It's a sobering reminder of the importance of randomized clinical trials. On paper, LB should last 72 hours and provide better coverage than ropivacaine, which lasts 12. But in the actual clinical environment, the AUC for pain was comparable. It makes you think about the cost-benefit analysis as well, given that LB is significantly more expensive than ropivacaine.
Definitely. If there's no difference in recovery or opioid consumption between high-dose LB and ropivacaine, the justification for the extra cost becomes difficult, especially in a value-based care model. Let's talk about the patient population for a second. These were patients aged 18 to 65, ASA 1 to 3. Do you think the results would change in an older, more frail population where we are even more desperate to avoid opioids? The study didn't specifically break down the elderly population, but since the primary issues seem to be the spread and onset of the LB in the paravertebral space, those mechanical factors would likely remain the same regardless of age.
Fair point. Any other interesting tidbits from the secondary outcomes?
They looked at postoperative recovery, things like time to first flatus, time to chest tube removal, and length of hospital stay. There were no significant differences. This suggests that while regional anesthesia is great for recovery, the specific choice of local anesthetic, LB versus ropivacaine, didn't translate into a faster discharge in this specific trial.
So if you're a resident on the wards and the attending asks why we aren't using liposomal bupivacaine for all our thoracic blocks, what's your answer based on this paper?
I'd say that according to the 2026 Wren et al. Study, LB in a single-point TPVB doesn't provide superior analgesia compared to ropivacaine. While high-dose LB is better than low-dose, it doesn't offer a significant opioid-sparing advantage over the traditional ropivacaine block, and we might need better injection techniques or adjuvant plain bupivacaine to truly see the benefits of the liposomal formulation.
Excellent summary. It's all about the evidence. We want the best for our patients, but we also have to be scientists. This study provides a very clear, albeit perhaps unexpected answer for our clinical practice.
It certainly does. It'll be interesting to see if the optimized strategies the authors mentioned, like multi-point injections, change the game in the next few years.
Well, that's all the time we have for today's deep dive. Thank you, Dr. Alara, for breaking down the data.
My pleasure, Dr. Aris.
And thank you to our listeners. Remember to check the show notes for the full citation of the study. We'll see you next time on the Neurosurgery Hub podcast.
Goodbye, everyone.